Congenital ventricular septal defect occurs as a result of incomplete septation of the ventricles. Most congenital defects are perimembranous at the junction of the membranes and the muscular portion, at the junction of membrane at the muscular portions. Clinical features usually asymptomatic. Small ventricular septal defect, usually asymmetric. Murmur found on auscultation. Large ventricular septal defect, dyspnea at rest or exertion, poor feeding or interrupted feeding, poor weight gain, easy fatigability, profuse perspiration, example head sweating, recurrent respiratory tract infections, and finally cyanosis. Physical examination. General examination and on precordial examination. General examination. Appearance sick looking, often malnutrition. Respiratory rate increased. Pulse rate increased, and volume good. Blood pressure normal. BP normal. Jugular venous pressure JVP, raised in congestive cardiac failure. On precordium examination, inspection, palpation, and auscultation. Inspection, hyperdynamic apex. On palpation, apex beat shifted to the left. And 30 in nature. Left parasternal hip. Thrill may be present, and loud P2 in pulmonary hypertension. On auscultation, harsh pansystolic murmur, best heart at the lower left sternal border, in the third, fourth, and fifth intercostal space. Investigations include chest X-ray, PA view, number 1, number 2, ECG, number 3, echo, echocardiography. Chest X-ray, PA view, cardiomegaly, enlargement of the heart, increased pulmonary vascular marking, normal in small defect. ECG, normal in small defect. Left ventricular hypertrophy, left ventricular hypertrophy in large ventricular septal defect, biventricular hypertrophy when associated with pulmonary hypertension, biventricular hypertrophy, biventricular hypertrophy when associated with pulmonary hypertension, POF may be noted on peaked echocardiography for location and size of the ventricular septal defect and direction of blood flow. Treatment. Small ventricular septal defect. In case of small ventricular septal defect, counsel patient that it is a benign disease and surgery is not required. Usually can close spontaneously 30 to 50% by 2 years of age. Moderate to large ventricular septal defect. Treatment. Supportive treatment. B. Transcatheter device closure. C. Surgical. Small ventricular septal defect, counsel patient that it is a benign disease and surgery is not required. Moderate to severe large ventricular septal defect. Supportive treatment includes nutrition, high calorie diet, furosemide 1 to 3 milligram per kg per day in 2 to 3 divided dose. After reducing agent, ACE inhibitor, enalapril, captopril, and captopril, digoxin. When diuretics and ACE inhibitors fails to control symptoms. Transcatheter device closure. Surgical indications. Patient of any age. With ventricular septal defect having symptoms and FTD cannot control medically. Infants between 6 to 12 months of age with moderate to large ventricular septal defect associated with pulmonary hypertension. Even symptoms are medically controlled. Infants between 6 to 12 months of age, severe large ventricular septal defect associated with pulmonary hypertension. Patient older than 24 months of age. With a QP/QS ratio greater than 2:1. Complications of ventricular septal defect. Complications of ventricular septal defect: heart failure, infective endocarditis, recurrent respiratory tract infection, pulmonary hypertension, Eisenmenger syndrome, reversal of shunt. Eisenmenger syndrome, pulmonary hypertension, and Eisenmenger syndrome. A 16 months old boy presented with history of recurrent respiratory tract infection since early infancy. With history of recurrent respiratory tract infections since early infancy, he is not growing well and becomes tired during breastfeeding. He has a grade 3 systolic murmur on auscultation of precordium. A 16 months old boy presented with history of recurrent respiratory tract infections since early infancy. He is not growing well and becomes tired during breastfeeding. He has a grade 3 systolic murmur. Grade 3 systolic murmur on auscultation of precordium. Mention three probable diagnoses. Ventricular septal defect, tetralogy of Fallot, Epstein anomaly. Ventricular septal defect, three probable diagnoses: ventricular septal defect, tetralogy of Fallot, and Epstein anomaly. These are three differentials. Now clinical evaluation. Clinical evaluation cyanosis present in tetralogy of Fallot and Epstein anomalies. Cyanosis, clubbing present in tetralogy of Fallot and Epstein anomaly. Precordium examination. On precordium examination, ventricular septal defect, tetralogy of Fallot and Epstein anomaly. Inspection, palpation and auscultation. Inspection, palpation and auscultation. Number 1, ventricular septal defect. On inspection, we get hyperdynamic precordium. Inspection. On palpation, apex beat shifted to the left. And thrusting. Palpable P2 present and a left parasternal hip. Present. On auscultation, we get S1 and S2 audible in all areas. Pansystolic murmur, lower left sternal border. Pansystolic murmur. In case of tetralogy of Fallot or TOF, on inspection we get maybe bulge due to right ventricular hypertrophy. On palpation, apex beat in normal position. And palpable P2 and left parasternal hip absent. Palpable P2 and left parasternal hip absent. Auscultation, S1 normal, S1 normal, S2 loud and single. A loud ejection systolic murmur is heard in pulmonary area. A loud ejection systolic murmur is heard in pulmonary area. Then Epstein anomaly. Epstein anomaly inspection. For inspection it is normal. Palpation. Systolic thrill in tricuspid area. Systolic thrill. Epstein. On palpation we get systolic thrill, in tricuspid area, bicuspid and tricuspid. On auscultation we get S1 normal, S2 loud, and a loud pansystolic murmur over the left sternal border due to tricuspid regurgitation. A loud pansystolic murmur. Loud pansystolic murmur over lower left sternal border due to tricuspid regurgitation. Due to tricuspid regurgitation. 3 probable diagnoses: atrial septal defect, ventricular septal defect, and patent ductus arteriosus. ECG: right bundle branch block, atrial septal defect, ventricular septal defect, and patent ductus. Atrial 3 probable investigations. Difference between atrial septal defect, ventricular septal defect, and patent ductus arteriosus. Atrial septal defect, ventricular septal defect, and patent ductus arteriosus. ECG. What we get in ECG? Right bundle branch block. Ventricular septal defect. Normal in small defects. Large shunts results in left atrium and left ventricular enlargement. Large shunt result in left atrium and left ventricular enlargement. In patent ductus arteriosus, left ventricular hypertrophy. We get left ventricular hypertrophy. Chest X-ray. We get in atrial septal defect we get cardiomegaly, enlargement of the heart. Ventricular septal defect we get enlargement of the main pulmonary artery. Then left atrium, left ventricle with increased pulmonary vascular markings. Normal in patent ductus arteriosus. Echocardiography. Atrial septal defect. Atrial septal defect. Color Doppler demonstrate flow across the defects. Left atrium and left ventricle enlargement. Defect may be directly visualized. Color Doppler demonstrate flow across the defect. hypertrophied pattern ductus arteriosus, hypertrophied left ventricle, hypertrophied left ventricle, color Doppler demonstrates the flow across the defect.